Okay, we can go ahead and get started. Welcome everyone. This is our third webinar, just getting to know our program, Rush Emergency Medicine. Thank you everyone for coming out tonight. I know there's lots of events going on. We really appreciate all of you guys coming and taking the time to come learn about our program and meet us. We can just start with introducing a few people. I'm Kaya. I'm one of the third-year EM residents here at Rush. Who else is on tonight? If you guys just are panelists, if y'all want to individually unmute yourselves and you can say hi.
Sure, I'll start.
Yeah.
Chris Wong, I'm the medical director at Rush Copley in Aurora. Good to see everyone.
What else do we have?
I'm Carolyn Clayton. I'm the clerkship director here at Rush, and I'm also one of the core faculty members.
I'm Harrison. I'm one of the twos at Rush.
And Harrison.
I'm the simulation director at Rush and one of the core faculty.
Hi, I'm Jeanette. I'm a first-year resident at Rush, and I went to Rush Medical College as well.
I'm Drew. I'm a second year at Rush. I also went to Rush Medical School.
I'm Scott Heiner. I'm the Associate Program Director.
So I think we have Patwari on.
I'm Rahul Patwari. I'm one of the core faculty.
And then
what's up, Chris?
Hey, good to see you.
We have Dr. Pfeiffer.
Hi, Dr. Pfeiffer, Penny Pfeiffer. I'm at Sinai.
Awesome. Well, everyone, welcome. I'm really excited for everyone to be here tonight. We're going to talk about some of our sites, our rotation, some of the skills you can expect to learn. So we can go ahead and get started. Why don't we start with Mount Sinai? Dr. Pfeiffer, if you just want to tell us a little bit about Sinai, the emergency department, the feel of the ED, and then we can talk about the resident experience after you're done.
Sure. So Sinai is a level 1 trauma center. So whenever the residents are there, we try to have them on the trauma side so that they're seeing more critical patients. It's more of a county feel there. So you have a poorer population. So you see a lot of different things that you might not see elsewhere, but it's very busy. You get a lot of procedures there. And yeah, it's usually one resident at a time that's on. So you kind of get whatever comes through the door. It's a lot of learning. You're usually one-on-one with your attending, which I thought was really nice. I did a rotation through there as a resident, and I thought it was a great learning experience.
Awesome. I guess, Jeanette, I know you just finished a month at Sinai, so if you want to let us know how that went.
Yeah, so I was actually on the trauma surgery service at Sinai for the last month. It was amazing. It's made me really excited to do my ED rotation at Sinai next because it is a very interesting, field, patient population, like tons of procedures. First time I'd seen a couple of thoracotomies, which was very, very interesting. As a intern on the trauma service team, you really do, you help with all the trauma codes. You do procedures like chest tubes, central lines like crash fem lines and subclavian lines. And you're also managing the trauma patients on the floor, which is really good learning. But yeah, the ED experience, I'm looking forward to it because it looks very busy, tons of different things you'll see walk in the door.
Yeah, I definitely agree. We didn't, when I was an intern, we were still doing trauma at Cook County, so we didn't get the trauma experience our intern year, but the EM months at Sinai have always been amazing. Lots of procedures, lots of crazy cases you get to see. The one thing I do really like about the Sinai emergency department is their trauma bay is not separate. So you get to see still your bread and butter ER patients. At the same time, you may have a trauma come in. So you're helping to manage both patients rather than having a completely separate trauma bay, which is how the Cook County program is set up. I know Drew was there when I was also at Sinai this past year. Drew, if you want to let us know your thoughts.
Yeah, I did trauma there in June and then did my EM as a PGY2 in July. It's one of my favorite, if not my favorite place that we rotate. because you get to see a lot of different patient population. You get a lot of autonomy. There's a lot of procedures to be had there too. And one of the benefits of working just one-on-one with an attending, most part, is that you do a lot of those procedures. You're supervised, but you are very hands-on, which I think really helps. And it's a great place to work. I really enjoyed it. So I'm very pro Sinai on our rotations.
Anyone else want to add anything about Sinai, either the trauma or the EM experience before we move on?
I can throw something out there. So I think it's a great like contrast that we have between Rush and Sinai, because Rush is a very like tertiary academic center, has a lot of resources, and Sinai is not that. So you know, like Dr. Pfeiffer was saying, you know, you're usually the only resident, and there's only one attending for 10 of the hours of the 24. So, you know, it's just you and one other doctor that are managing the 24 plus patients that are there. So I think it like helps to kind of round out our experience as residents, because it's, there's a stark difference there. So yeah.
Awesome, thank you guys. Why don't we go on to Rush Copley? We rotate at Copley during our second year as well as our third year. We can first, I guess, just hear from the director there.
Okay, so Rush Copley, we're in Aurora, Illinois, which is the second largest city in Illinois. We see about 65,000 a year, between 65 and 70 a year. We have two sections of our ER. We have a 19-bed main ER, and then we have a 14-bed. It used to be our fast track, but it's pretty much our intermediate. You know, ESI levels 3, 4s, and 5s go there. 2 residents a month. We get the second year and third years from the program. They mainly rotate into our main ER, the 19-bed side. We're a level 2 trauma center, but we're really the only, out west side, western suburb of Chicago, not too many level 1 trauma centers out this way. So we basically see a good chunk of level 1 trauma our way. You know, different feel probably from Rush in the city. We're a big community hospital. We have pretty much a lot of services available, except I guess what we're lacking is a PICU, but in the ER we have pretty much everything. Pretty busy ER. I think the residents get a pretty good feeling for a busy community hospital. We have pretty good coverage for 19 beds. We usually have 2 attendings on, plus a PA covering those 19 beds, in addition to the resident on. And we usually only try to schedule 1 resident at a time, so that you guys aren't overlapping, so that you guys get the most procedures and best experience possible. Yeah, so you know, feel free to ask any questions.
Thank you. Yeah, I mean, I did my copy month last year, my second year, and it was fantastic. I kind of harking on what Dr. Pfeiffer said, the nice thing about being at the Rush in the main, in the city, as well as our Sinai, as well as Copley, you really do get that one-on-one feel with the attending. It's just literally you and the attending, which is really nice because you get to learn from them. And I felt like the community feel at Copley was very different than the Sinai feel. So it's very well-rounded. And I think that's fantastic exposure for all of us to have starting from intern year going forward, so that by the time we get to our third year, we can have a little better idea of what type of practice style we want to go into. Yeah, I definitely have seen my fair share of crazy cases at Copley, even in terms of trauma, a lot of blunt trauma, just because major freeways, major highways, car accidents, rollovers, you still get some of your penetrating trauma, but definitely different than what we see here in
yeah, we get some yeah, we have like these farm roads that people go 80, 90 miles per hour on, and, you know, 4-wheeler accidents, which I've never saw when I was training in the city. So, yeah, a good amount of blunt trauma. a lot of high-speed motorcycle accidents and things like that. And then this summer we had a pretty good amount of penetrating too. So
yeah. We have a question here from one of the applicants. How many weeks of trauma do residents get to do each year? Maybe if one of the residents wants to answer that, and then maybe one of our faculty can kind of give a little bit more hindsight of why we designed our trauma the way we did.
Somebody correct me if I'm wrong, but you get 4 weeks at Sinai as an intern, and then you do 4 weeks at Cook County as a second year. We don't have any dedicated trauma months as a third year, but I will say that, like, kind of what people have been mentioning. I mean, you do a month of EM at Sinai, and it's only 24 beds for the emergency department, including all the traumas. So you're the airway on every single trauma. So you still kind of have that, like, you're still part of the primary assessment, primary survey, and you're still involved. And then similar, I talked to Kat Buckley, who was the resident at Copley earlier today, and she was saying how, like, she actually saw a fair amount last month. And so while we don't have any dedicated months more than the 2, you still have a fair amount of trauma exposure. Somebody else correct me.
We also added the SICU for the third years at Sinai.
Yeah.
So they respond to all the traumas. They get all the intubated patients and all, basically the post-operative patients. So it's essentially like a trauma ICU month for us.
And when you're the SICU senior, you actually do come down and respond to all the traumas with the rest of the trauma team. So you're helping to manage them. So I know one of our co-residents, Nuper Shah, was there in July, and she got a bunch of chest tubes and to help with thoracotomies and things like that. Even though she was a SICU senior, you still actively manage the trauma patients, which is fantastic. And kind of just, that's one of the unique things about our program is intern year, you actually get to do a month of trauma, which I think is fantastic because you're thrown right into the gauntlet.
Very true.
It's a fantastic experience, I think.
Yeah, it's been amazing. I'll echo that. It was really great, like being on trauma early on. And I mean, I guess this will be the case all year. When you roll into a trauma, it's called like a code yellow at Sinai. Everyone runs down to the ED. And then like you see your third year, like SICU resident there. And then we had another intern there this year. So she was at the head of the bed doing the intubation. It's kind of cool to see your rush colleagues there when you're responding to traumas. And then another cool aspect is you get to meet other EM residents from other programs, which was very cool. So I had one other intern from Resurrection on with me, and then one from Swedish. So it was very cool because you meet your other like EM Chicago colleagues, and I hope I see them again at other Chicago area events and other rotations at Sinai. So that was really fun.
Penny rotated the same month as me. I didn't know you got a job. I'm so excited there.
Yeah, I remember. I was like, oh yeah, I was with him last year. I'll be here attending.
From a strategy kind of standpoint, from a leadership standpoint, it's very deliberate the way we kind of pick the sites. Is, you know, we know a lot of the students love trauma. It's you know, the glamour, the stuff that people see in the movies. A lot of the students are interested in trauma. We know that we're not a level 1 trauma center at Rush, and so we made sure very deliberately to make sure that our sites and our rotations cover more trauma than you probably would and see in a lot of places. And that's why Copley and Sinai are strategically picked, because even though they're not technically trauma months, you do see a lot of trauma on those months. And so you have your set trauma months, but you also have kind of just a ton of extra trauma that we don't even count as a trauma month, just by being in the EDs and being the residents there. And one of the changes that people always ask, we just actually added this year for the first time, is the SICU trauma experience as a third year. That was actually based on kind of a lot of feedback from some of our attendings that rotated there as residents, that it was a phenomenal experience. You have a ton of independence in the unit. You're really running a trauma ICU almost by yourself. And so then we actually trialed it out last year with 4 of our residents that went there on elective. And, you know, it's a grueling month, but the feedback was phenomenal. They all said they loved it and we should do it. And so therefore we added it this year. For our third years now, we're doing that as a month. And Sinai really wanted us there. They really respect our residents, and they want us to come over there. And our residents, based on last year, said it was an awesome month and we should go there. And so therefore we added kind of the extra trauma SICU month this year.
And then, oh, sorry, go ahead.
If I could just add, even though you guys' ER months are not technically trauma designated months, you're getting a lot of the, sorry, I have dogs, sorry if you can hear them. You get a lot of the traumatic procedures as the ER resident. So you're gonna get the bloody airways, the GSWs to the neck or the head, the reductions we try to do as well. So some residents might only get on their trauma months or at a, you know, on the trauma service.
And I was one of those core faculty that advocated to add in that sticky rotation and the time in the Sinai ER. I said a little bit in the chat, so I won't say more. I don't think my internet connection is that great tonight. So.
And then just to kind of finish off our trauma sites, we also do go to Cook County Trauma. Second years do trauma at Cook County. Again, it's very different field than Mount Sinai because the trauma bay at county is separate than the emergency department. So when you're doing your trauma month, you are wholly dedicated with just the trauma team. And the trauma team is composed of EM residents from different programs, Northwestern, we're there, and I forget the last program that's still there as well. And then also surgery residents, and then it's run by the trauma surgeons. And you're not seeing your bread and butter EM patients at all. It's strictly just trauma. So that's another 4-week rotation, lots of cool, great procedures. They still do DPL, so you may get to see a DPL when you're there. And then, yeah, I don't know if anyone did their trauma at county already, Harrison or Drew. Yeah, it's a very different experience. It's fantastic, great learning. But again, I think well-rounded on trauma. And then kind of one of our other community sites for emergency medicine is Rush Oak Park. I actually haven't done my month there yet. I know Dr. Hawk, you kind of just started moonlighting there a little bit. I'm not sure if any of the other faculty have ever worked there or have any insight at Rush Oak Park that they can share with us.
Yeah, so I did just start doing some shifts over at Rush Oak Park, and my initial observations and thoughts about the differences are that Rush Oak Park is a very efficient, very rapidly functioning community hospital. And I have already seen my personal efficiency improve some. So I think after seeing the contrast in different locations, it's really helpful to have that added experience at Rush Oak Park as well.
Awesome, thank you. Another question we had just come up: what is the general relationship like with EM residents at other programs? I know, Jeanette, you kind of mentioned a little bit about working with some of the other residents. I don't know if anyone else, one of the other residents, kind of wants to talk about that.
I'm happy to say something. That was a thing that was important to me when I was picking a residency. I was trying to figure out which city I wanted to go to. And I did a rotation at the city that I'm from. And although there are three different residency programs there, they don't do anything together. There's no like inter-residency anything. In contrast, there are 8 or 9-ish programs in Chicago now, and every year we have the Windy City EM conference in the fall, which is like it's all the residency programs that join in. Our like Illinois state chapter, ISEP, is pretty active in keeping a lot of like the whole state's emergency medicine programs, like having different events and different like webinars and conferences. So, and then like people have mentioned, we do rotations where we have to interact with other residents. So it's just like fun because, you know, you spend, you know, and Jeanette knows this too, you spend a month with like 1 or 2, depending on when the shift changes or the month changes, with like one of the President's Resurrection interns as an intern. And then you see them at the conference, like at a couple months later. So it's just fun to interact with these people.
All right, why don't we talk a little bit more about our rotations at Rush University. So besides just EM, you have a few rotations. You have MICU, you have PICU, there's OB-GYN and L&D, as well as anesthesia. I don't know what other am I forgetting?
Ultrasound.
Ultrasound rotation,
And orientation month.
orientation month. Yeah. Jeanette, maybe you want to give us a little bit info about orientation month?
Sure, yeah. So it's the first month of July for new residents in EM here at Rush, and it's amazing. It's really nice because it's a combination of lectures. We do 6 shifts and a ton of sim, a ton of procedure prep. It's a very, very nice introduction to like residency, to kind of, get your feet wet, but not be totally in over your head yet. I talked to some residents at other programs that were just kind of thrown in, and I felt like the orientation month at Rush was excellent. I felt very prepared to then move into my trauma rotation, which is one of the longer hours, like procedure heavy, intense rotations. And doing a lot of sim during orientation month was great for that. It's also a great way to really interact with your co-residents, even during this time of COVID and a lot of masks and like less social stuff. It was still really, really nice to have that orientation month to just like, meet people and kind of have like the space to mingle without being like all off at different rotations right from the bat. So I really liked it.
And then also intern year, you do ultrasound. Dr. Gottlieb's not on tonight. He'll be at one of our future events, but we do a lot of ultrasound. You do 2 weeks of dedicated ultrasound your intern year, a week second year, and a week third year. And then we have ultrasound built into our foundation's didactics as well. So lots of exposure to ultrasound. Our faculty are pretty enthusiastic about it. So if you're on shift ever and you're like, oh, I'm just going to throw the probe on, everyone's pretty comfortable with that. So I think that's fantastic. And having Dr. Gottlieb there is really, really awesome. And then besides ultrasound, one of the other really big things about our didactics and some of the skills we really hone in on is sim. And Dr. Hawk is actually our sim director, and she has fantastic cases always for us. So if she can tell us a little bit more about that.
So yeah, the simulation program at Rush started out as kind of focusing on the resuscitation and procedural skills in a way that propels residents to feel comfortable leading these as early as possible in your residencies. So we have twice monthly simulations for every resident. And what that usually consists of is about 2 to 3 high fidelity cases, so resuscitations that you do in small groups with faculty debriefing. And then the other kind of thing that happens in the month would be a 2 rotation station in the ER, where we do in situ simulation with our nurses, pharmacy, respiratory therapy. Child life has been involved in those cases, to really run through what would happen in an emergency department where we had a resuscitation like this happen. So we have in situ simulation happening once a month, and then the in sim lab once a month. And then it's basically an 18-month curriculum that kind of shadows the 18-month conference curriculum and was designed to be a little bit off time-wise, so that you weren't talking about GI problems and then going to sim about GI problems, because it doesn't reinforce it quite as well. So we thought a lot about how to arrange the sim cases such that you get reinforcement of what you cover in conference, but we're not covering the same things per se. And every resuscitation that we can think of is included. I'll talk a little bit about fellowships and the simulation fellowship that happens at Rush in October, but our sim fellow is heavily involved in the education that happens during simulation and is constantly writing new and exciting cases. And so that's another educator that you'd come in contact with, is our simulation fellow, and or our resident director of sim, which is one of our PGY3s. So sim is I think it's great. I do a lot of it. There's a lot of opportunities to grow with simulation if you want to do some work outside of the typical sim days that we already have. And so we're open to lots of different ideas.
Thank you, Dr. Hawk. Harrison and Drew, I know since you've already done MICU intern year, do you guys want to let us know about how your MICU rotation went?
Sure. I also just came off MICU nights today, so I can tell you about what second year is as well. I don't know though, I think we changed it this year, didn't we, within Redley? But essentially you're just kind of there's multiple teams in the MICU at Rush. There's a fellow kind of running, home crit fellow kind of running the whole ward essentially. And then you are admitting the patients. You can get a lot of procedures in there as well if you are so inclined. On my MICU month, a lot of the internal medicine residents didn't want to do any procedures, so I got to do a lot of theirs as well, which is very helpful. It's essentially like you're in internal medicine for the month. It's a good rotation to learn a lot about like critical patients because Rush is such a good tertiary care center that you'll get a lot of those kind of patients. And then second year we do nights. So I just finished 2 weeks of nights there. And basically you're admitting all of the patients that come in after 8 p.m. There's about 24 to 27 patients in the floor at all times. And you're splitting that between yourself and a third year IM resident. So you're managing about 12 to 13 patients. You're also doing procedures when patients come in. And it's definitely a different feel than working during the day, but I think the combination of both provides a good, well-rounded aspect of medical ICU.
And again, from kind of the admin side, the MICU experience has been one we've kind of been toiling with a lot based on feedback. And Drew kind of mentioned a little bit the second year rotation now. We're an academic center. There's just a lot of learners around, and so one of the switches we made is actually going more to nights for the residents, so that they're actually have less other learners around and more independence in there. And that was kind of based on feedback of people that went through the rotation. And one of the other changes we are actually making in the next week or two, I think is when it goes live, is they're actually creating a new ICU. It's going to be a combined kind of ICU, med, surge, OB, cardiac. It's actually going to be run kind of by us. And so there's going to be a 1 and a 3 that are kind of going to be the lead kind of physician team in there. And so a lot of that was just based on the fact that, we always want more independence. We want to run those things, and they really like what we've done. And so that's going to be hopefully going live very shortly, and kind of changing a little bit of the ICU experience as well.
Thanks, guys. One of the questions was, how are procedures split between EM and consultants and specialists? Like it was mentioned in the chat at Copley, really there aren't many other residents. It's just the EM residents and this FM residents, so procedures are yours. Same as Sinai, every ED patient you pick up, if there's a procedure, that's your procedure to do, whether it's intubation, the central line, a peripheral ultrasound, any procedure you can think of. Also, even reductions. There's typically in-house ortho doesn't come down as often. I had my first hip reduction at Sinai in July. So you get to do a lot of procedures at our community sites. And when you're at Rush downtown, EM procedures are EM procedures, right? Airways, your central line. The way ortho works is sometimes, depending if it's a pediatric patient or not, we'll have to call down the ortho team to help us kind of manage the reduction. We'll typically do the conscious sedation, and then ortho will help with the reduction. And that kind of also depends on your adult patients. It kind of just the severity of what the dislocation or fracture is. So a lot of the procedures, if it's your patient, you get to do. If it's an intern and a third year on shift, I think a lot of the third years are very open to having the interns do the procedures. This is your time to learn and our time to teach. So whether it's doing the intubation or a line or whatnot. So definitely a lot of procedural opportunities starting your intern year.
Yeah, and I guess just to kind of add to that, kind of the culture at Rush, at least the main site, is that, our emergency medicine folks do our own procedures. And, if there's a very difficult, fracture dislocation that you want ortho to come by before because it's a little more complicated, they are more than happy to come and watch you do it, because that means less note writing and less work for them essentially. But then, it's a pro, because then that means that the next time you won't necessarily feel obligated to call them. You'd be like, okay, I know that this is more complicated than your traditional reduction, but I've done it before. And then, speaking what Kay was just saying about kind of like having a 1 and a 3 split, the culture also is definitely much like interns are supposed to learn and master the skills so that by second year you can be the teacher. So that was definitely how it was laid out to me at the beginning of intern year, and I think that definitely held up. And I remember thinking at one point how like, oh man, I wonder, like, am I gonna get enough of each type of procedure that by second year I'm gonna feel like I can do that? And I would say definitely so, because even now, even there are plenty of shifts where it's just me and like an off-service internal medicine resident or an OB resident who has no interest in doing an LP. You know what I mean? That's not at all in their scope of practice, and they don't want to be involved with that. So I think that our system is set up well.
Thank you, Harrison. I'm going to jump back to kind of just finishing out some of our other rotations that we do before we take some more questions. Intern year, you also do L&D and anesthesia. This year, I think it's a new combined rotation where you're in 2 weeks L&D, 2 weeks anesthesia, basically catching babies and intubating people in the OR. L&D was my least favorite rotation, so if anyone else has anything happy to say about it, please go ahead and let us know about your L&D experience.
In general, almost every residency call you guys will be on for a webinar. If you ask anybody, OB is a necessary evil. We have to be there. We have to get 10 deliveries. We're not going to be obstetricians. We're really getting the deliveries. So that's kind of what we shorten the rotation, just to make sure we get the deliveries. We have a really good relationship with OB, and it's nice to build, and get to know them and see them when they come down. But honestly, you're there essentially to make sure you get required deliveries. You're not there to go practice C-sections or anything else. So we were able to kind of cut it down to make sure we still can get the numbers without, having to spend a full month there. But in general, you guys probably shouldn't.
And you also get to.
You probably should.
You also get to catch simulated babies.
Yes, and Dr. Hawk's got simulated babies.
So we can do up to 30% simulated procedures if needed, and we have the opportunity to catch simulated babies a couple times a year.
But in general, whenever you guys are looking at places, it's going to be some sort of 2 to 4 weeks of mandatory OB. I highly recommend not choosing a residency based on an OB experience, unless you're going into OB.
It has other benefits too. I think that for me, at least, getting to know a couple of the senior OB residents really well, because now I know that I can call them, like if I'm going to page OB and I'm like, oh gosh, who is it? And then I see that it's Kate Derby, I'm like, oh, okay, this is going to be a great conversation, So that's an added benefit too, just getting to know other residents instead of just having like the name. You like actually have a personality that you can like relate to. So that helps later.
And then second year, some of your rotations include PICU and PEDS acute care. So there's a little bit more focus on pediatric population in your second year. I did my PICU rotation right after kind of all the COVID stuff started. So it was a very different and a unique experience. Definitely had some of those kids that were sick with the PMISC or whatever they ended up calling it. So PICU is fantastic. You get to take care of lots of sick kids. The attendings are all fantastic. Dr. Wilkerson actually won our consultant, or I think like our faculty, like non-EM faculty award of the year. She's our PICU, one of the PICU attendings and PICU director. So she's fantastic. I really enjoyed my PICU rotation. You just get a lot more comfortable seeing and managing sick kids. And then you also do PEDS acute care, which is our walk-in clinic in our PEDS ambulatory care building. It's basically a mini PEDS ET. You're seeing just like in and out, 20, 30 kids maybe. It goes by super fast. So lots of PEDS exposure. And then one of the elective opportunities we do have is a PEDS EM rotation at Advocate Lutheran General out in Park Ridge. I was one of the residents who did that this year, and it was fantastic. I had like 15 reductions in my 2 weeks there, a bunch of LPs, and again, a lot of blunt trauma out in Park Ridge just because of a lot of rollover MVC. So lots of PEDS exposure. Your second year. And then kind of third year, you're focusing more back on EM, lots of EM months, and then you have some selective time, both second and third year. And then you also do tox in your third year, which is fantastic just because we have 3 tox trained faculty in our program, which is great to learn from. Dr. Swoboda actually is, and Dr. Nicolaides is also staff at the Poison Control Center. So I think that's a fantastic experience and opportunity we have as well. I don't know if anyone else wants to kind of add in a little bit more about our rotations, and then we can talk more about the questions.
I think, and yeah, echoing kind of what we've been talking about, I thought it was an awesome month for like medicine. You know, at least for me, when I was looking at other residencies, my question that I would always ask is, what's your weakest part of your program? And many or most of the programs that I asked that, they told me their peds experience, just because it's hard to have like a big volume of sick kids. But since Rush is a tertiary like center, and we're a big referral catchment area, a lot of community sites send their sick kids to our PICU. So it's actually kind of a fun month, because there was multiple patients in the PICU that were sent in from like Sinai and from Copley that my co-residents had taken care of. So it was fun for just kind of like oh man, what were they like then? Like, oh, I can give you an update a week later. And then it definitely did feel, so that was my first month of second year. And that was definitely much more of like a more senior role. You're the only resident there from 4 p.m. until like 7 a.m. the next morning. So it's like a long and grueling month for sure, just because of the hours, but you also have a lot of independence. It's just you and the PICU attending. Our PICU attendings are in-house. There's no fellow at Rush. So it was definitely a very good month for learning medicine.
Since we kind of were talking about some of the elective opportunities, we have a question here. What are some of the more popular elective rotations offered in third year? So elective time, you have 2 weeks your second year and 4 weeks your third year, so a total of 6 weeks. We have a huge variety of electives that residents have already started. I did the pediatric EM elective this year. A few of the other electives we have is a global EM elective, 2 weeks, where previous residents, obviously this was pre-COVID, have gotten to travel. I think they went to Haiti and the Dominican Republic. One of our residents from last year set up a rotation out in Hawaii, which was an opportunity. So if you're interested in social and global EM, there's definitely elective time to do that. This year, one of our residents, she was really interested in EMS and flight medicine. So she wanted to do a flight rotation and had everything set up, but then COVID happened. So I'm not sure if she'll be able to hopefully pursue that sometime during her third year. There's elective in admin, I think, where you get to kind of, if you're interested in going into some sort of administrative position later on, you get to shadow and work with some of the admin and emergency departments. What else? I can find the list, but there's
residents have also done additional addiction medicine. This is a kind of a weird year, obviously, because the kind of with COVID hitting, we couldn't go off campus to do elective, and so a lot of the ones that were going to be happening couldn't happen, so they had to happen in-house. One of our residents was going to be going, kind of set him up with a rural elective out in Oregon and a ED that we knew to get it done for rural medicine, but unfortunately we weren't allowed to leave. But there are those options. Essentially, if there's something you really want to do and we can make it work, whether if it's a wilderness month, if it's a rural month, international month, we could try to help facilitate it. This is all assuming we don't have travel bans and can move in the future by the time you guys are cycling through. A lot of other rotations that actually we've had really good feedback sound weird, but ID and nephrology, we've had some residents, one who actually just graduated did critical care as a fellowship. And so you need more medicine, you need more months under a medicine attending to actually get in a critical care fellowship. And so I actually did months, and one was actually in the ICU at Copley, and said it was actually a really fantastic month. And then also have done rotations in nephrology and ID at Rush. And those have, you think during med school, like, I don't really want more ID and more nephrology, because we all try to get away from those. But those are actually really well received, and supposedly the faculty are awesome teachers. And so those are actually really good months to go through. So we have a ton of in-house options, which currently seems to be more than the out-of-house, just based on the pandemic. But whenever we can travel again, if you've got something you're passionate about, we will kind of help facilitate it and make it happen.
Yeah, I know one of our residents graduated last year, did a burn selective at County. So he rotated with the burn team over at County. So definitely lots of opportunities. And if there's something you're interested in and it's already not established, obviously with COVID, we'll just have to figure out something, whether it's something that you can do in the future or not. So definitely lots of elective opportunities. So hopefully that answers the question about some of the subspecialty interests as well. And then someone had asked about EMS and event medicine and wilderness medicine. Dr. Heinrich kind of mentioned about that, but if anyone knows more about any of the event medicine opportunities that we have, besides Chicago. So we volunteer at the Chicago Marathon. Obviously this year it's canceled, but we typically do have a booth, a medical booth there. Rush internally, also you can be the doc on call for the Chicago Symphony Orchestra, where you get 2 tickets to go to the orchestra, and then you're the doc on call. If there's an emergency, you respond. If not, hey, you got a pretty cool date night of going to the orchestra. Other than that, we're actually the receiving center for a lot of the events that go on at Soldier Field and the United Center, just because of where we're located. Mount Sinai is located right next to where Riot Fest, is that what it's called? It's one of those concerts that happens. So even if we're not at the event itself, it definitely feels like that. I remember working Lollapalooza weekend, both my intern year and second year, and it was just crazy. So you definitely get to see your share of patients coming from these specific events, not necessarily us going out into the arenas to kind of work, if that makes sense. Yes, Pitchfork. I think Pitchfork it is. What else? There's a few questions about can you speak about, no, we already answered that. Maybe
there's a question about which I think is worth mentioning about getting shifts off or covered for COVID or other reasons.
Yes.
Being a new-ish program, we did not before this year, or a couple months ago, I guess, have an official formal policy of if you had to call off. But now we do. I mean, I think that's just kind of one of the growing pains. It had been a year and we were like, oh, I guess we should have this in writing. So, getting things covered is very easy. At least at the main campus for sure, there's plenty of people are willing to switch, and there's so many EM residents in our program that people have to cover all the time. And then there's, if for whatever reason you can't go to work, A, you should not. And then B, there's a whole designated list of where the residents would be pulled from. So I forget where the first place is. I can't remember if it's tox or ultrasound or something. But somewhere where if they lost a resident, it's not, it's not a big deal at all, and they would just fill in the role.
For interns, it's OB and anesthesia get pulled first for coverage.
Noted.
Yeah.
And then someone had asked about, we dealt a lot with COVID, and what was the situation if someone got sick and with family members. Harrison was right on the spot with that. Really, I think the entire emergency department in the hospital is very invested in the residents. And we felt very invested in by our program directors and our entire admin that if, we did not feel comfortable, that was taken into consideration. If someone got sick, they had the time. And even if someone's family members got sick, we were definitely awarded the opportunity to kind of switch shifts and get the time off to be with sick family members. So I think the overall response was absolutely fantastic. And as a resident, that really goes towards our wellness, overall mental wellness. And I thought that was, it was very different than, what we hear from other residents and whatnot in different hospitals that kind of just had a very different experience. Kind of just finishing off some more of the important skills that I think we really get a good exposure to is quality improvements. Our entire residency is involved in quality improvements, and you have to do a QI project, but our program is built out such that if you're not interested and you don't want to start your own project, there's already projects going on and everyone's kind of automatically just involved, and it's not that much of a time commitment. So Dr. Clayton, if you don't mind talking a little bit about quality improvement.
Sure. So like Kaya said, all of the residents are assigned to groups. And we cover things, they're kind of standard things to cover. We cover 72-hour returns. So those patients who were discharged from the ER who end up coming back within 72 hours. We cover ICU upgrades. So a patient was admitted to a general floor, was upgraded within 24 hours. Was there something we missed, or was it really just a progression of illness? We look at some of our left without data, and those are kind of quarterly presentations, if I'm remembering correctly. And they all have faculty presence, but they're really a resident run experience. So we may help the residents pull epic reports and kind of go through cases and run anything past them, but really it's the senior residents who kind of take the charge on those and run through the cases, assign them to some junior residents, and then we kind of present them at conference. So it's a great way to kind of get some feedback about patients that we're seeing and things that we could be doing differently. One of the other things I wanted to just mention briefly in terms of electives. At Rush, we do a lot in terms of throughput, lean management, all that kind of exciting stuff. And I'm currently our medical director for ED operations, so I'm doing a lot of that now myself, for better or worse. And there are some people who are really interested in it. So some of our residents have participated when we've done some of our overhauls of certain areas, refining some of our flow, some of our throughput. So those are also experiences for people who have those interests. And I think one of the strengths about Rush is that because we're new, we don't have a lot of, we have certain things well established and certain things not. So if I've had residents say to me, you know, I have no idea if I'm interested in teaching. Can I come and help with the med students once in a while, but I don't maybe want to do it for a whole elective? No problem. So it's like kind of a great way to get your feet wet in certain areas and see if you're interested without having to do a full longer commitment. Same thing again for lean management stuff. So I think there's that opportunity to kind of build something on your own if you're interested and have a little bit of it, you know, are looking to create a little niche for yourself. But then there are also more established electives as well. So there's kind of a nice balance there.
Awesome. Thank you, Dr. Clayton. Then kind of just to finish off with some of like the really important skills that you get involved with just starting from intern years. Our didactics are really interactive, and we've set it up that it's not just sitting there for 5 hours and you're in conference and listening to people lecture. It's a combination of sim, ultrasound, we do foundations and oral boards cases. And then one of the really great things I really love about our didactics is we have like this 5-minute bundle that Dr. Patwari is really involved with. And this really hones in on your skills of EKG reading and reading plain films. And even sometimes we may do some more detailed imaging reviews. If Dr. Patwari, you can kind of talk to us a little bit about the 5-minute bundle.
Yeah, sure. So we use that time in conference really to talk about those skills that you talked about. We start in the intern year during that first month with a little bit of introduction on how to read x-rays and how to do EKGs. But we've got a whole 1-year curriculum that is based on reading EKGs and x-rays. And we pull those from interesting cases that we've seen in the emergency department. And so usually we'll pull some, you know, a mix. There could be some things that are easy, but are classic that you really need to know. And there are some that are challenging that, you know, need a little bit of work and thinking to get through. And then there's a little bit of explanation that goes with it. We'll try to get that out to everyone a little bit earlier in the week so that they can look at it and then come to the session so that we can discuss it. There's 3 things that usually fit in that 5-minute bundle, which really lasts longer than 5 minutes. First, there's an article presentation by one of the residents. And so we can go over one of the newer articles and give a quick summary of that. And then either EKG or X-ray or imaging, really any kind of imaging.
Awesome. Thank you. And let's just kind of take the last 10 minutes, since we're almost done here, to answer everyone's questions. I have most of them written down. The first few are more likely our APDs will be able to answer. How DO friendly is your program, and do you require USMLE or just COMLEX is okay? Dr. Heinrich or Dr. Gore?
Sure. I think we're very deal friendly. In general, we try to look at the total package of the student. We're not as much of a numbers based program. We don't have a specific USMLE cutoff. They do factor in, but we try to look at more of a holistic approach. We don't want to miss students that may not have done well on a standardized test, but crush the rest of their med school and have great experiences. And so we really do, it's exhausting, but we really do look at every application. So I'd say, DO friendly. I'd say we have many DOs in our program. And it's not really a big factor when we're looking through. We're just kind of looking to see the best student. In terms of the COMLEX question, as someone who advises students, I know this is really tricky. It's hard because it's expensive and it's more of a test. We do accept COMLEX scores. Is it a general advising, not us specifically? Sometimes it's if possible, better to take both, because there are programs that just won't necessarily convert. And sometimes you may be hindering yourself by programs. If you don't see USMLE, they just may not look. And so it's not us specifically, because we actually do look, but some other programs may not do it. So general advising, if able, it may help you with a broader spectrum of programs, because some places, if they don't see USMLE tag, they just won't actually either send out interviews or get to that point of going through the application. But in general, we try to look at every student from anywhere and try to figure out who's going to be the best fit and who's going to succeed the best by us.
We are also very IMG friendly. I myself graduated from St. George's. One of our chiefs last year went to an IMG school. Our second year class and our intern class, there's typically 1 or 2 IMGs each class. So I think our program is very receptive to that and very open to that. Like Dr. Heinrich said, they do really look at the holistic approach, and it's not just all about board scores and where you went to medical school. So hopefully that kind of answers some of the questions from our IMGs who are on with us tonight. You are a pretty new program. Are there any additions or changes to rotations or sites that you are looking at currently? Kind of mentioned some of the rotation changes. We added the SICU this year, and hopefully the new hybrid ICU experience should be up soon, whenever that gets running. In terms of rotation sites, I'm not sure if Dr. Heinrich, Dr. Gore know more about that.
In general, we're always reevaluating, and I know this was one of the other questions as we see kind of feedback responsive. That's what we try to do. That's why we've had one is because we're relatively new. I don't like to think of us as a new program anymore, because this is now our 4th year out. But we generally try to be responsive to the residents. So we added the SICU because they loved it. We changed the MICU because they didn't love it initially. We added the new MICU because to get more experiences. So we in general are always looking to change. We don't want to kind of get set doing something because we've always done it. In terms of community sites, we're looking into places we've had before that were very successful and great feedback that had to be kind of discontinued for certain administrative type reasons. We're always looking to get back at whatever place will give the best experience. So, if we think there's a place you can get really good community experiences, then we'll obviously try to get as many of those as we can.
Awesome, thank you. There was a question about traveling from site to site. So the sites that we travel to, which include trauma at Cook County, we share the same campus, so you can park at Rush and then walk over to County. Mount Sinai is maybe 5 minutes away from Rush, literally like a little bit west, and you get free parking there as well. Rush Oak Park, depending on the traffic, if you live in the general downtown area, it can take anywhere from 10 to 15 minutes, so maybe sometimes 30 minutes. And then Rush Copley is in Aurora. And even from me, which I used to live in the South Loop, which is like downtown by the lake, for me to travel from there all the way to Aurora, it would take me an hour max. There are definitely residents who didn't have a car and were still able to make it work. You could do the Zip car, you could do Uber, whatnot. And Rush has a really great policy of reimbursing. I think I got reimbursed more money than I actually spent on gas when I traveled to Rush Oak Park. So you definitely get reimbursed, whether it's an Uber or whatnot, or if you're driving your own car out there. What else? There was a question about, do the responsibilities change as programs, as interns progress to 3rd years? Maybe Harrison and Drew, you can start since you just started second year and what you think so far, so, and then I can add in a little bit.
Yeah, I think that a lot of people have responded to that question.
Cool.
Yeah, but just to echo it in case people are not reading it, I think that we do a good job of from day one of intern year, you are expected and can take any patient. And so, obviously you're going to have people around, but I think, again, it's kind of our culture that like you need to be expected to see sick patients as a second year and as a third year. So like, why are we going to wait until day one of second year? What magically changes then? Nothing. So I think that was one thing that I really like about Rush as a residency is that other programs, as a one, you're not allowed to see stroke patients. I think that's personally, I think that's a silly way to do things because, you're going to need to see more. And if you have an extra year of seeing stroke patients, you're going to see an extra year's worth of variety. So I think that it's good to have it how we have it.
The general philosophy is the patients, and I know Dr. Hawk said it, but the patients you see don't change. It just depends on how close we are to you when you're seeing them. And I think it's generally, that's why I picked the residency I went to, and the reason we created our residency this way also is, there's no reason, as Harrison said, that you shouldn't see everybody. It just depends on how close we are and how much oversight you have. And the more you do it, the further away we get from the room and can sit at my desk and watch and do things a little differently.
And I think one of the other things about like kind of front loading intern year with a bunch of EM months is our PD had mentioned this a few weeks ago. You should be learning EM from EM docs, right? So to put you in a bunch of off-service rotations your intern year really doesn't make sense. So I think, having a lot of EM experience intern year really sets you up to do well your second and third year. And it goes with the fact that you get to see the sickest of the sickest patients starting your intern year. So I feel great coming on as a third year, right? I had all these EM months my intern year, got to do a lot of cool procedures, had sick patients, went on to second year and third year. You feel so much more confident the way that it was structured. So I think that's definitely beneficial. Some of the other questions, where do Rush EM grads end up? We do have a whole session kind of dedicated to mentorship, fellowship, and jobs. We just graduated our first class last year. Half, I think, went into fellowship and half went into like community or an academic program. Some are our fellows at Rush. Dr. Chen is addiction med fellow. Dr. Goldstein, he came on as faculty at Rush as well. A few of our residents have gone out to New York in a teaching fellowship as well as ICU fellowship. Some are in Cleveland, where else? California, Dallas. So definitely a big variety, but you'll get to meet a bunch of them and kind of ask those questions if you're able to join us at one of our later sessions. Any other burning questions that I missed that we really should talk about tonight? I think that was most of it. Oh, how is the medical district in terms of where patients go and ambulance receive triage?
I threw in an answer in that comment.
Oh, great. Awesome. So I think it's in the comment section. But yeah, traumas don't come here, obviously, to Rush, obviously, because Cook County is the trauma center, so all the traumas go there. But I don't think that I have never noticed any like problem with EMS funds coming to Rush ever, so.
No, we have a nice ambulance bay now and a little snack room for them, so our volume has increased significantly.
Yeah, and like Dr. Hawk said, we definitely have our drop-off traumas that come in, so you'll still see gunshot wounds and MVCs and stab victims just walking their way into the emergency department at Rush. So you will still see some trauma at our main ED. But yeah, if I think that pretty much sums up everything for tonight. I'm just gonna screen share this. I hope I do this the right way. I'm gonna screen share so you guys can kind of see just the rest of our series that we have laid out for you. We're gonna be talking a little bit more about Chicago, our selection process, and the diversity efforts at Rush overall, as well as our emergency department, a session for wellness. And then this one on October 6th, I know a lot of you guys have questions about where our residents end up. What about fellowship versus just going out into the community? We have a lot of fellowship trained faculty. We have a lot of fellows in our EM program, as well as we have our first graduating class. So a bunch of people will be joining in. Then we'll kind of close it off with our social and community health outreach programs, our social and community health track that a lot of us are involved with. So again, thank you everyone for joining us tonight. We'll be posting this video. So if you know if any of your friends or co-students couldn't make it tonight, they'll definitely be able to view this online. Either I'll email it, and it's also posted to our Rush GME website. Yeah, thank you everyone, and have a good night, guys.